This is a rather difficult topic to talk about because like magnesium that is an orphan among all cations, chloride is an orphan in anions because has generated less interest until very recently. I have no conflict of interest. As you know, chloride is one of the most abundant anion in a body. Mostly extracellular fluid, 88% of it, and 12% intracellular fluid. It gets really absorbed easily and fast, and 100% from the GI tract, and about 2% is eliminated via stool, and the rest mainly from kidney and some from skin. Obviously, the total body content of chloride is about 85 grams, 3.5 gram daily intake. Among 20,000 milliequivalent of chloride that is filtered on a daily basis, most of it is reabsorbed. Only 180 milliequivalent per day is eliminated via kidney. And that makes the percentage of filtered load reabsorbed about 99%. And the clearance of chloride is about 1.3 ml per minute. The reabsorption of chloride is very passive. So as you can see, this is the y-axis is tubular fluid to plasma concentration of these substances. So as you know, creatinine is secreted in proximal tubules. Therefore, the tubular concentration of creatinine when it goes through, the filtrate goes through proximal tubule increases over time in comparison with plasma. In comparison with bicarbonate, glucose, and amino acid that are actively reabsorbed, so their concentration is less than plasma in filtrate. As you can see, chloride and sodium are reabsorbed in an isoosmolar way for chloride case in a passive form. The way that it works is that sodium is passively absorbed after active removal of intracellular sodium with NAK ATPase. And that results in increasing water absorption through the membrane, and therefore increases the luminal chloride concentration, therefore passive absorption. In addition, negative potential of lumen increases, that increases chloride reabsorption from proximal tubule. When we pass through a proximal tubule, then in a thin part of loop of Henle, there is significant reabsorption of water. Therefore, chloride concentration increases until we reach the thick part. And in thick part, chloride is actively reabsorbed in sodium potassium 2 chloride channel. And this way, we see that chloride concentration continues to decline. As you can see, up to this point, there is significant reabsorption of chloride. However, in the latter part of the nephron, in distal tubule and collecting duct, there is increasing chloride concentration of filtrate over time. At the end of the day, when urine is generated, has almost isoosmolar concentration of chloride. Hypochloremia can be seen in some type of diarrhea. It's called cholera diarrhea. It can be seen in venous adenomas, or it can be seen in mutations in pediatric population. Nasogastric tube secretions or vomiting. Renal loss has been seen in Addison and salt-losing nephropathy. Hyperchloremia has seen in diarrhea, hyperchloremic acidosis that happens during diarrhea, Cushing's syndrome, hyperaldosteronism, and respiratory acidosis are associated with high chloride level. Chloride channel is something that is also not as well defined or studied. However, there are significant number of chloride channels as transmembrane proteins that are not only in plasma membranes, they are within intracellular organelle membranes as well. They can participate in cell volume regulation, transepithelial transportation, and regulation of electrical excitability of the cells. And the regulators of this particular protein are transmembrane voltage, intracellular fluid content. So cells that are swollen, this membrane acts differently. Binding of signaling molecules, other ions, protein kinases, and binding of or hydrolysis of ATP can potentially change the performance of this particular channel. And its mutation causes a significant number of diseases that are well known to us. For example, in cystic fibrosis, there's a decrease in transepithelial transportation of chloride, Bartter syndrome, increased muscle excitability in myotonia congenita, decreased endocytosis in Dent's disease, and decreased extracellular acidification of osteoclasts that results osteoporosis, also described in chloride channel mutations. Now, what is important, at least in vitro, is that chloride is a vasoconstrictor for afferent arteriole. So this is isolated afferent arteriole in vitro with different concentration of chloride. So when concentration of chloride increases, the lumen diameter of afferent arteriole continues to decline. Therefore, that can conclude that having higher chloride concentration results significant vasoconstriction. Obviously, when they isolate the afferent arteriole from the kidneys, these afferent arterioles are moved along with JGA. Therefore, JGA could potentially result this afferent arteriole vasoconstriction. Now, as far as the mechanism, when chloride load is given or when the chloride is elevated, there is changes in GFR. As you remember, when everything is iso-osmolar. So when you start with a higher chloride concentration in plasma, filtrate will have higher concentration of chloride. And as you know, when chloride concentration in blood is elevated, that results in tubular concentration of chloride, which is a signaling process for JGA or tubular-glomerular feedback. That results vasoconstriction on afferent arteriole, therefore decrease in GFR. This is particularly exaggerated in diseases like sepsis and other reasons for afferent arterial vasoconstriction. Now, the fluid that we use often is normal saline, and this has been shown in many presentations in these meetings. However, I cannot resist to say that normal saline is a solution that is nothing normal about it. As you can see, it is completely different from plasma concentration of sodium and chloride, and as you see, the normal concentration of sodium is 135 to 145. It's 154 in normal saline, and chloride is significantly higher than normal saline. And in comparison, you can see that probably the closest composition of solution that is closest to plasma is probably plasmolite. However, other solutions outside of normal saline have a little closer to normal level of chloride concentration. Now, in this study, randomized clinical trial, a small study, post-kidney transplantation patients, they received 2 liters of normal saline versus 2 liters of lactated ringer. Because the small sample, they weren't able to identify differences in serum creatinine level or acute kidney injury site. However, they obviously showed chloride level in normal saline group was significantly higher, therefore pH was significantly lower, metabolic acidosis was significantly more frequent, and interestingly, hyperkalemia was more often among the patients with normal saline, which basically shows that with using high chloride concentration, we open the floodgate of intercellular potassium reservoir to intravascular space, therefore we can increase potassium significantly faster than lactated ringer that actually contains potassium. And in this crossover randomized clinical trial of normal volunteers, as you can see, patients who received 2 liters normal saline versus 2 liters of plasmolite had significantly higher chloride for about 4 hours. In these patients, about 35 minutes cortical perfusion was significantly lower in normal saline group, and renal blood flow was significantly lower for about 90 minutes among patients, normal individuals who received normal saline. The purpose of giving boluses of fluid among patients, critically ill patients, is to increase intravascular space. These normal individuals that are supposed to urinate all that 2 liters within minutes, within 30 to 60 minutes, had significantly higher weight for 4 consecutive hours after receiving normal saline versus plasmolite. And indeed, when they looked into where that additional weight is, they found most of it in extravascular volume. So that defies the purpose of using fluid boluses potentially to enhance the volume of intravascular space. Now, this is a study that was done by Professor Bellomo's group. It was a pre and post evaluation of the chloride concentration of fluid for resuscitation and impact in acute kidney injury. And the group was able to show there's significant higher chance of acute kidney injury at the time that high chloride concentration was used in comparison with chloride-restricted group. In this retrospective study of one-to-one propensity match group of 3,000 patients in each group, 3,000 patients did receive normal saline exclusively. The other 3,000 received balanced solution for a percentage of their resuscitation. What authors were able to show was that absolute in-hospital mortality was significantly lower on patients who received balanced solution as a part of their resuscitation. And indeed, if you look into the percentage of balanced solution, the higher balanced solution they used, the lower mortality was. Now, this is a split trial. It's a 2,000-patient randomized clinical trial, very well done and designed study. As a pilot for a larger study that hopefully we will see the results, look into mostly post-surgical patients and with low comorbidities. Most of these patients received about 1.9 liter of fluid to compare a balanced solution versus high chloride concentration solution. And the study was not positive, didn't show any difference between the two groups. An argument is that usually sicker patients with higher doses of sodium chloride potentially can show a signal. Now, as a result, we kind of wanted to see what is the impact of chloride per se, not what we do to these patients. What is the impact of baseline chloride in prediction of outcomes? So we looked into about 14,000 ICU admissions in the course of 7 years in our center. And we identified about 4,000 patients that they had baseline serum creatinine available. They didn't have CKD stage 4 and 5. They didn't have AKI before their admission to ICU. And they had measured serum chloride within 1 month prior to admission. So what we found was that about 38 to 40% admitted with hypochloremia, 60% admitted with normal chloremia or eukhloremia, and a small percentage of patients were admitted with hyperchloremia. And among those who were admitted with low chloride level, volume resuscitation resulted decrease in the incidence of hypochloremia over the course of ICU admission. In addition, in eukhloremic patients, there is a little smaller percentage of these patients had eukhloremia during the course of admission. What you can see is that the percentage of patients with hyperchloremia after ICU admission, as a result of what we do, most likely due to resuscitation, is significantly increased during the course of ICU admission. Now, what we found was that those who were admitted with sodium chloride of 94 and less, they had significantly higher chance of acute kidney injury through the course of admission. As also you can see, there's a U-shaped relationship between chloride level and acute kidney injury incidence. And those who didn't have acute kidney injury have actually normal chloride level acts as a protective association. The same relationship was noted in mortality. Particularly, we noted that patients who had low chloride on admission had higher mortality than those who had very high serum chloride as a baseline 1 month prior to admission. And same for length of stay, although less obvious, but we found the same U-shaped relationship. Now, what we did eventually was to kind of evaluate what kind of fluid. We wanted to see why these patients have higher mortality. One of the factors we were able to find was that those who were hypochloremic on admission, they received significantly higher amount of normal saline, 2 liters versus 1.2 liters in eukhloremic and 1.4 liters in hyperchloremic patients. And that could potentially participate in development of higher risk of acute kidney injury among these patients. Also, they receive higher not doses, higher frequency of Lasix boluses as well. Now, when we looked into multivariate analysis to see what are the factors associated with higher hospital mortality among patients with what are the factors that are associated with hypochloremia among patients admitted in ICU, we found older patients have a higher chance of hypochloremia, females. A lot of comorbidities were associated with hypochloremia. These are generally patients that are iller looking, failure to thrive. They come to ICU and they receive more baseline diuretics before ICU admission as well. This study was done in a different way with a different question in our institution by Professor Chen, and they looked into hospital admission, not ICU admission. They looked into 3-year worth of all hospital admissions, about 150,000 patients. They were able to identify 76,000 unique patients that were admitted in that 3-year course. And then about 56,000 of them had follow-up serum chloride measured in 48 hours. Now, hazard ratio of mortality increases above 1 when chloride is very low at the baseline hospital admission or chloride is very high at hospital admission. Now, mortality, the same finding that we had as a U-shape increase in mortality, they found higher mortality in two extreme of the spectrum of baseline or hospital admission serum chloride. As Professor Chen just showed, those with anion metabolic acidosis, the impact of high chloride level on mortality was significantly exaggerated and based on mechanisms that she described very well. Now, when they looked into amount of increase in serum chloride that impact on hospital mortality, they noted that if serum chloride through the course of hospital admission increases more than 2, hazard ratio of mortality after adjustment for all other comorbidities is significantly higher. And indeed, there is a dose-response relationship. So if the increase is more than 4 millimole per liter, then you have twice as much chance of mortality among these patients. Not only that, you remain in ICU a little longer. So if you have higher chloride within 48 hours of admission, you have also lower survival among these patients was observed. Now, switching gears to chloride and potassium disorders among CRRT patients as well. This is a study, post-hoc analysis of a randomized clinical trial of 210 patients. They looked into 0 hour and 24 hours after initiation of CRRT and different electrolytes. As you can see, hypocalcemia was very common after adjustment for albumin. It decreased the incidence. Hyperphosphatemia is very common. What is very obvious is that hyperkalemia obviously very common before initiation. We correct that. However, a lot of patients develop hypokalemia during the course of study due to correction of acidosis and so forth. There was no impact on 28-day and 90-day mortality based on electrolyte abnormalities at the time 0, nor was found any difference in 28 and 90-day mortality, 24-hour on CRRT. As of interest, point of interest is that those who had hyperphosphatemia on admission or hypophosphatemia, hypophosphatemia, they had significantly higher mortality if their phosphorus and admission was more than 4.5. And if 24 hours after CRRT, they still had hyperphosphatemia, they had significantly higher mortality as well. These are two different mechanisms. The first group are those who come in with hyperphosphatemia, most likely due to acute kidney injury. And the second group are those who not only have retention of phosphorus, they potentially release more phosphorus due to cell lysis and critical illness as well. And indeed, a few years back, we presented this in ASN in 2013, that the replacement rate of phosphorus is a predictive for mortality. So the higher replacement you need to have to protect the phosphorus in a normal level, the lower mortality you have. So those who needed no phosphorus to maintain their phosphorus in normal level, they had highest mortality. Now for chloride, that is the topic of this topic, we looked into day 1 to day 7 of among 190, about 2,000 patients, chloride concentration in day 1 to day 7 of CRRT. As you can see, mean starts kind of an upward trajectory, and in addition, variability decreases. The confidence interval, the interquartile range is smaller because we bring all chloride level to a normal range. And indeed, when we looked into the chloride concentration of solutions that we use, it's actually in a high side. It's higher than normal range. When we looked into correlation of chloride concentration in day 1 before CRRT versus day 1 to 7 of CRRT, the correlation decreases over time. So regardless of whatever chloride you come in to start CRRT, at the end of the day, CRRT ends up in a kind of mean level for all patients. What we found was that none of these was associated with any ICU outcome, chloride level from day 1 to day 7, nor other electrolytes. The only thing we found was that there is a weak but statistically significant relationship with increased mortality in ICU and lower ICU admission chloride level, which we found in previous study as well. Take-home point, chloride plays an important role in physiology. High chloride load is associated with AKI mortality, increased length of stay. Baseline ICU hypochloremia is associated with, again, acute kidney injury and mortality. These patients receive more normal saline and diuretics. Admission hospital chloride also is associated with U-shape, increased chance of mortality. Higher increase in chloride level during hospital increases mortality, is associated with higher mortality as well. And CRRT electrolyte changes, they all regress to mean, they all become in a normal range, and that is not associated with changes in outcome. With that, I thank you for your attention.